Hi, I'm Dr. Larry Eichenfield from the University of California, San Diego, and Rady Children's Hospital, where I'm a professor of dermatology and pediatrics and run the pediatric derm unit and vice chair of the department. I want to talk about the Maui dermatology atopic dermatitis session and my contributions to that, and really a few takeaways based upon sort of changing practice and new medicines that we have in hand. First thing I discuss is topical therapy, still a major part of atopic dermatitis therapy across the ages. And both some of the concerns we have with, I say over-concern with topical steroid withdrawal or topical steroid addiction. We have patients who are coming in with basic stories of a minimal amount of topical corticosteroid use, but then they stop it, and then a week later the child has recurrence of the eczema, and they're saying, oh, it's from the topical steroids. So we're trying to be clear to educate people about what topical steroid withdrawal or systemic steroid withdrawal symptoms can look like, what the findings are. We just had an article that just came out trying to come up with core criteria for this phenomena, and I think it's very important to define the phenomena so people understand that there's a lot of persistent or recurrent atopic dermatitis that isn't topical steroid withdrawal. On the other hand, we have an incredible changing set of non-steroidal topicals in our hands now. And I discussed sort of our senior non-steroidals. That would be tacrolimus and pimecrolimus, who are in their 20s since they came out around turn of the century. And then our sort of, I guess the adolescent one would be topical crisaborole. And then we have our newer ones with a lot of change within the past year. Topical ruxolitinib, which had been approved ages 12 years of age and older, now down to age 2, the same formulation, with a 20% max body surface area, but highly successful topical agent. Roflumilast, 2 different concentrations approved for atopic dermatitis, the 0.15% from 6 years of age and older, and the 0.05% for 2 to 5-year-olds. Really good, well-designed clinical studies showing efficacy and very high tolerance. And then we have the aryl hydrocarbon receptor agonist tapinarof, approved ages 2 years of age and older. So I think, translation to clinical practice, these drugs can be used as monotherapy instead of topical corticosteroids. They can be used in regimens with each other or in regimens with more traditional topical steroids or non-steroidals. They've really changed clinical practice in a way that I think is really positive for patients. Then I moved on to discuss a little bit about counseling with systemic agents in atopic dermatitis, particularly some of the issues that patients have where they're concerned if a patient starting on a biologic, is it going to be a forever medicine? And really new data and new interpretations of data on our systemic biologic agents that can show prolonged efficacy off drug and or remission after an extended course of medicine, or a decrease in the sort of remnant state of eczema after a year or two. It could be dupilumab, or it could be lebrikizumab, or one of our others. We also have had the addition of nemolizumab approval, as well as lebrikizumab, to our collection of agents, along with tralokinumab and dupilumab. And so there's more counseling to do as we go through our selection of these medicines that are incredibly life-changing for our patients with atopic dermatitis. And lastly, I just discussed an update on JAK inhibitors, both in kids and adults, so with the takeaway being that we really have extended safety data that can be put into the perspective of these agents that can be really can have the highest degree of success in terms of symptoms and control of signs of atopic dermatitis. So obviously, atopic dermatitis, an area of common practice with lots of changes that are bringing positive benefits to our patients.